Hi, my name is Lynn Cagle, and I'll be talking about subarachnoid hemorrhages for my case study. I worked on a stroke unit, and I saw a lot of subarachnoid hemorrhages. I think that the most interesting part about working with the subarachnoids was the chance to get to go to angio or interventional radiology to do an angiogram and see the neurosurgeon inject verapamil or just take a look at the vessels, injecting contrast in, and just being able to get to visualize that, and because you could see it live, and that was pretty cool. So the patient that I was taking care of presented with the worst headache of her life. She I don't think had any history of any stroke or bleeds. She came in and maybe had a history of smoking, I think. A lot of patients that this happens to, there's not any stroke history because these aneurysms in this, it's in their sacral space, they're called saccular aneurysms, and they rupture, and they're in the subarachnoid space. So the subarachnoid hemorrhage, it has to be in the space, it's in between the pia mater and the arachnid mater, which they are connected, and that's where the cerebral blood vessels run through. So it's usually pretty, it can be pretty devastating, depending upon the size of the rupture, the location of it, etc. So, the diagnostic test would be first a CT scan. That will be, especially in an acute phase, you'll need a CT scan to verify the bleed. It'll appear white on a non-contrast head ECT, and where it would normally be black in the arachnoid space. So typically that CT scan will verify the bleed, and then they can also be graded on a scale, the Hunt-Hess scale, to kind of help communicate to other physicians, the severity of the bleed. And the Hunt-Hess scale is 1 through 5, 1 being like mild symptoms, mild headache, no deficits, 5 being coma or dyscerebrate posturing, and everything in between, kind of as the headache got worse, and then the level of consciousness was to go down based on how bad the bleed was. Another diagnostic test would be TCDs, or transcranial Doppler. Daily they would have to check this. It would be it's an ultrasound, so they'll come to the bedside every morning and check with a ultrasound the velocity of the blood in the cerebral arteries. A lot of times, they'll write them up on the board, and you'll say, okay, what do these numbers look different or worse? Or mostly you're just looking for a big change, or one side being more or less than the other by a major amount. The doctors usually like to see them written up there every morning. So those are some of the things. Plus, the nursing would be responsible for Q1 hour neuro checks, coming in and doing drift checks to see that first the patient is oriented. This patient was always oriented. She could tell me, her birthday and everything, and seemed normal, completely normal, and she had no drift. She'd raise her arms, nothing, until when she didn't. So we were doing a drift check, and she was unable to hold her arm all the way up, and it just kept falling back to the or kind of going into this kind of going down And it was very like, oh, well, she's just sitting here talking to us and her arm's going down. And the doctor happened to walk in and saw it and was like, okay, we're going to take her to angio now. And they would immediately take her there. And then we went down, and she had some vasospasm, which is a complication of this, hemorrhage. So what that is the narrowing of the cerebral arteries in the brain, and that can be bad because you're gonna have decreased blood flow, and it can cause another type of ischemia. And so what the neurosurgeon will do is go in through the groin and inject the verapamil into the vessel, which will help dilate the vessel and open it back up. And you get to see it like happening, which is really kind of cool. The patient ended up having a good outcome from that, or at least was able to then orient. She has had to stay in the hospital. There's like a 21-day risk for these subarachnoid hemorrhages, where usually between like day 7 and 14 are the main times when these patients have a risk for vasospasm, and they're usually in the ICU. They could, and more likely, have an EVD, which is a drain in their ventricular space. This will help us monitor their ICP, and the ICP is sometimes affected from these hemorrhages because of the extra fluid in the brain. This is a box, and you can only fit so much in that box. So if there's a lot of blood, or if there's a lot of hydrocephalus caused from the bleed or from edema from the injury, it could be traumatic, it could be an aneurysm rupture. All of these things could cause increased pressure into the brain, and a lot of times they'll have a brain drain, and we'll be monitoring their ICPs. So if they're above 20 for greater than 15 minutes, we'll end up calling the doctor. They can sometimes tell us to drop the drain some more off, or sometimes they have to pop their top, or do some burr holes to release some pressure. And this can happen at the bedside sometimes, and that's crazy too. But this lady did not have that. She actually had very good outcomes, which is not typical. The actual, I think it's like, 40% of these patients die, and 50 to 60% have permanent disabilities. This lady had quite extensive hospital stay, because they have to be here for those 2 weeks, those 14 days post-bleed, and then sometimes have to go to rehab or whatever. And then, but once, they're stable enough to go home, she was, and she did, and that was great, because we don't see that very often in the ICU. A lot with the bleeds we see usually make them have caused their ICP and level of consciousness to change, which is a possibility when your Hunt-Hess score is higher, like a 4 and a 5. You're on the ventilator most likely, because your ICP is so unstable, or your bleed has caused your neurological state to be unable to protect your airway, or have seizures and whatnot. So treatment, as we've been discussing, is most likely an EVD, gradual or routine CT scans to kind of check edema and bleeds. Often they'll do angios just to take a look. What else? They will do the TCDs. That's part of the treatment, but also part of the testing. And Nimodipine is a medication that we use to prevent vasospasm. It's given every 4 hours and it's given 21 days. Sometimes it'll drop the blood pressure and you'll have to split the doses up every 2 hours, but that's a pretty common thing. This patient was also on nimodipine. It's a pretty straightforward, like, you know, you want to also keep these patients euvolemic, which is, even as far as their fluids go. Okay, so as far as this lady, her outcome was good. A lot of times they're not, and we use that Hunt-Hess score to communicate, what their prognosis is, as well as the Fisher, which is based on their CT scan results. So, but it was exciting to see this patient do so well and see the things that we did for her. So, that's all I got. Thanks.